So good morning, everyone. I'll be talking on the warning signs of inflammatory Cnvm. So before that, you need to understand that why the inflammatory Cnvm is different from the other Cnvm. So if you see that the neovascularization is a very rare complication, but can happen in any case of uveitis, and you need to understand that the angiogenic stimulus of uveitis is responsible for that. And if you go into deep, you will realize that there is increase in the VEGF within the retinal neurons and the RP cells of the patients with uveitis, and also there is increased VEGF immunoreactivity in the ganglion cells and various cells in the patients with uveitis. So with this background, you have to understand that any macrophages and all, they can secrete enzyme which can damage the cells and degrade the Bruch's membrane, and side by side the release of cytokine can promote the growth of the blood vessels, and with the break in the Bruch's membrane, which is sometimes inflammation induced, can cause inflammatory Cnvm. Now, if you talk about the risk factor, there is eyes with AC cells 2+ or worse had a significant higher incidence, 2-year incidence of Cnvm. Also, the pre-retinal neovascularization simultaneously or before the diagnosis of Cnvm had more than 3-fold higher risk of CNV compared to the eyes with inactive inflammation. And these are the patients at higher risk, and you need to understand that sometimes the active inflammation or ongoing chronic inflammation can be responsible for the Cnvm. Now, the entities at the risk, if you see there, that these are the entities which are at risk, and coming to the subtype, if you see that the most common with posterior uveitis and panuveitis, and very rare in anterior uveitis or intermediate uveitis. So we should have a high index of suspicion while monitoring these patients with uveitis. Now, as I told that the anterior uveitis is very associated with Cnvm, you see this 6-year-old child who is a known patient of JIA had a recurrent attack of anterior uveitis, and when he presented to us with a base-corrected visual acuity of 6/7.5, and 6/9 in the left eye, and you can see that the child was a typical JIA patient who was undergoing treatment with methotrexate and other drug, but we found that there was a Cnvm in this patient, so which was treated with anti-VEGF and responded very well. So you need to understand that in JIA, where the posterior segment is very uncommon, sometimes actually can be complicated by Cnvm also. Now let me take these 2 studies, one from our hospital and one from the PGI Chandigarh, and you can see that infective etiology is a common cause of Cnvm in our country, and both the PGI group and our group showed that it's almost same. 30% patients with inflammatory Cnvm had the tuberculous etiology, and also toxoplasmosis was much more common in this patient. Now, coming to the risk factor for inflammatory Cnvm, you need to understand that the uveitis with involvement of Bruch's membrane or choriocapillaries are higher risk, such as VKH and sympathetic ophthalmia. And also the bilateral uveitis already who had a history of other eye Cnvm are prone to develop that. Pre-retinal neovascularization, as I said, it's very important. So you need to, very important is that you need to explain this patient about the potential symptoms of the Cnvm, that is like scotoma, metamorphopsia, so that they can come very early to seek the medical care. And also the test, like you need to train them for the test like Amsler grid, and also you need to do imaging in this patient. So this is our data showing that the 71.4% of the patient had active uveitis at the diagnosis of Cnvm. So it's very important to treat this patient with for the proper control of the Cnvm. Now, just I want to show some cases where we have learned from the mistakes. So you have to be very careful. This is again, it's a very interesting paper from the Dr. Rima. You must go through this paper. So it says that the subtle peripapillary lesion appearing as a hypopigmented halo or hyperpigmented scar with or without SRF should arise the suspicion. A tiny 1/5 of the disc diameter single subretinal hemorrhage is also very important. And Cnvm can mimic sometimes the choroiditis lesions or scars. So you have to be very, very careful. Other features that actually precludes the prior diagnosis is that sunset glow fundus, significant background scarring as seen in serpiginous choroiditis, and also the factors like cataract, poorly dilating pupil, significant vitreitis actually sometimes aids to the confusion. Now this is experience that we found that the 45% of the cases the peripapillary CNVM was bilateral, and also the multifocal choroiditis was most common cause of peripapillary CNVM with VKH, and the posterior and panuveitis are most prone, and they are also associated with active inflammation. This is a patient actually presented with multiple choroiditis, healed multiple choroiditis patches, tuberculous choroiditis, treated with ATT and oral steroid, and you can clearly make out that there is a CNVM. So which the further imaging was picked up. But I'll show you another interesting case, a 42-year-old male, history of healed choroiditis for 8 years, ATT, treated with ATT and corticosteroid, inactive disease for last 4 years, and just came for an annual eye checkup. And you can see here everything was within normal limit, except for he was sometimes complaining of scotoma, but he was not very sure also. Just based on the suspicion, we just investigated, did the imaging, and it picked up a peripapillary CNVM. So sometimes peripapillary CNVM can be very subtle, and patient may only come with a simple symptom of scotoma. So don't ignore the subjective symptoms in uveitis patient. Sometimes even if they are asymptomatic, keep a high index of suspicion, and you have to remember that the peripapillary CNVM can remain asymptomatic initially, and also uveitis with previous optic disc involvement is at higher risk of developing peripapillary CNVM. This is another case where we missed the CNVM because of this choroidal granuloma. So we were busy in treating the choroidal granuloma, and later we realized that there was a CNVM also was beneath that. So sometimes you need to be very, very careful while handling this kind of cases. I'll show another case of sympathetic ophthalmia. Again, we are busy treating the exudative RD because it did not respond to the early treatment. So we give IVMP, and then finally started the patient on tofacitinib, oral steroid. And this was the picture when the patient presented to us. And later, actually, with all this medication, the patient responded well. We underwent cataract surgery. And finally, you see the vision from counting finger, it improved to 6/12. And later we realized that this patient also, we were busy in settling the exudative RD. There was one CNVM also growing. So it's very important to understand that while treating some entity, you may miss that. So I'll conclude here the inflammatory CNVM. So you have to remember that the chorioretinal inflammation is at high risk. Neglecting the subclinical and chronic inflammation can be dangerous. Value the subjective symptoms in uveitis patient, metamorphopsia or central scotoma, pay attention to it. Margin of the optic disc, choroidal scars should be examined very, very carefully. And the gold standard of diagnosing a CNVM is the imaging. Sometimes the dye, ICG or FFA, scores over the dry, like OCT or OCT in uveitis. So try to do that in uveitis, because it's not only you want to see the CNVM, you need to delineate also how active the inflammation is going on. So that's why dye sometimes scores more over the dry investigations in uveitis. Thank you. Thank you for your patience here.
Thank you very much.